You rather controversially posed me this question: do we have a one-size-fits-all drug? And what I'd like to do is to take colleagues through the data that we have in the ALK space and really talk about the pros and cons of all the drugs that we have and where we think they might fit in to our scenario. Thank you. These are my disclosures. So we've been using crizotinib for a while. We've stopped using it in general, and many of us still have a few patients still doing very well on crizotinib. So we should always remember what we started off from, which is that crizotinib is better than chemotherapy. Remember, the median progression-free survival of crizotinib in profile 1014 was 10.9 months, and that's something I want you to remember. And we also know from 1014, we had multiple lessons. We know that crizotinib is way better than chemotherapy. The due responses are better. But we know from 1014 that brain mets were common. It's about 26% in 1014. They had to be treated and stable. And we know that brain is a common site of progression. And that if you give SRS, you have risks such as radionecrosis and costs. And we can see from the subgroup of 1014 that the efficacy in patients with brain metastases was slightly inferior than those without brain metastases. If we look at all of the comparative data that we have on patients with next generation inhibitors after crizotinib with or without chemotherapy, we can see that by and large the next generation inhibitors are very active, with very good activity for alectinib in the pooled analysis data set, with very good intracranial control and a good progression-free survival in patients with CNS disease as well as without CNS disease. But we also see very similar data for brigatinib, and I would perhaps suggest that this has perhaps the best PFS post-crizotinib, very good intracranial activity, and more recently data with ensartinib, and also lorlatinib with a response rate of 70% and a median that's not been reached in a relatively small but non-mature data set for the post-crizotinib setting, but importantly, a very, very high intracranial response rate. So what is this data that we have on lorlatinib that's posed Nitesh to ask me this question? So this is the first big data set that we have, which is the phase 1, phase 2 multi-cohort study in which patients with both ALK and ROS-positive disease were recruited and treated according to different cohorts. So in the ALK group, we had the untreated patients. We had patients treated only with crizotinib and chemotherapy, and other cohorts with next generation ALK inhibitors. So what was the outcome? Well, we see that if you are untreated patients, we really have the best outcome with lorlatinib prompting the CROWN trial, which I'll go on to in a moment. And then we have patients with crizotinib, with or without chemotherapy, treated with lorlatinib, and we have really a very impressive median progression-free survival not reached in this trial at the time of presentation. Undoubtedly, lorlatinib is active if patients have progressed on next generation inhibitors with median progression-free survivals of between 5 and 7 months, but nowhere near what we see either upfront or post-crizotinib. Then we have some more data on how active lorlatinib is, and this is one of the supplemental tables showing the activity intracranially by each of the different groups. And we can see in patients progressing on crizotinib, it has huge intracranial activity with response rates of 85, 86, 87%, showing really that crizotinib is very limited in its intracranial control. But when we get on to other generation inhibitors, and then we use lorlatinib, yes, it does have very good intracranial activity, but we're a bit less in terms of its intracranial response rates, in between 55, 40, and 64%. But more importantly, if we look at the difference between intracranial and extracranial control, we have to remember these should be regarded as very separate compartments when we're talking about ALK, and I would perhaps suggest EGFR, but we can discuss that. We can see that in patients treated with crizotinib, we have a very good intracranial control and a very good extracranial control, but the extracranial control is much less than the intracranial control, reflecting the problems of crizotinib getting into the CNS. But also here with the next generation inhibitors, whilst we have very good intracranial control, we are limited with the extracranial responses that we see, with responses around 35, 36, 37% in patients progressing on next generation inhibitors. Now, we know that patients that progress on TKIs have a different set of acquired mutations. So these are the types of mutations that we saw in this trial in patients that received crizotinib. Whereas in patients that had received next generation inhibitors, we see a different spectrum of mutations dominated by the G1202R or the G1202 del genotype. So how does lorlatinib perform if you have these mutations present or if you don't have them present? So again, we found that according to ctDNA genotyping or tissue genotyping, that the response rates were very good if mutations were identified at 62% or 69%. But if mutations were not identified, then the response rates were much lower, almost halved at 32%, which translated to meaningful differences in progression-free survival, really with an impressive progression-free survival 11 months with mutations and more modest at 5.4 months without mutations, suggesting that lorlatinib is a very good drug for the brain, as we've discussed, more modest efficacy outside the brain, but much more potent if there is a ALK mutation there, meaning that there's still ALK-centered drive for the patient. Where you haven't got the ALK mutation, perhaps it's more modest efficacy. So how do patients then develop acquired resistance to lorlatinib, and what can we do about it? Well, we have a number of different resistance mechanisms identified. This is a French group who identified epidermal mesenchymal transition as a problem, and we and others have demonstrated this. This is a case with a patient with neuroendocrine transformation, transdifferentiation as an acquired resistance mechanism to lorlatinib. There can be bypass mechanisms and importantly compound mutations, and lorlatinib is characterized by resulting in a number of new acquired mutations. But more recently, colleagues at Memorial have demonstrated that MET amplification is also seen with acquired resistance for lorlatinib, although crizotinib seems not to have very much activity in this setting. Perhaps the newer MET inhibitors may be more appropriate in that setting. What about the toxicities of lorlatinib? Well, in this phase 1/2 trial, we see that lorlatinib, which is designed to get into the brain, has some very unusual toxicities. The vast majority of patients develop dyslipidemia, and this will require pharmacological intervention to treat. Patients also develop peripheral neuropathy, but nearly 35% of patients in this trial were developing some sort of cognitive or mood effect, which will require some sort of treatment if grade 2 or more. So how do we manage the toxicities of lorlatinib? Dr. Bauer and colleagues have presented a very nice paper showing how we should be managing this. This is the recommendations for dyslipidemia, requiring introduction or modification with lipid-lowering therapy, increasing the dose and possibly reducing the dose of lorlatinib if required. Of course, we also have the CNS adverse events, and these can be classified into three main groups: the cognitive events, the speech events, and the mood disturbance. There can be overlap of each of these, and these generally require dose reduction to manage. We also see a variety of very subtle neurocognitive effects, which Dr. Nagasaka and colleagues have written in a very nice paper about how to manage this in real life, including visual hallucinations, auditory hallucinations, olfactory hallucinations, speech issues, dream issues, impulse issues, personality change, and functional issues as well, all of which can be controlled with dose reduction. But perhaps there are other drugs which can be used after next generation inhibitors. This is a phase 2 trial which my colleague Dr. Stinchcombe presented at ASCO last year, in which patients with next generation inhibitors that were ALK positive were treated with brigatinib using the step-up dosing that we all know, 90 for a week followed by 180 milligrams. And you see a very comparable 40% response rate with a median progression-free survival, very comparable here of 6.4 months. Well, all the actions now in the frontline setting. So where should we be using lorlatinib? Is there a role in the frontline setting? This is the CROWN study, which was presented a couple of weeks ago by my colleague, Dr. Solomon. This was a highly anticipated trial in the ALK field, comparing the role of lorlatinib with crizotinib, randomizing patients in a phase 3 trial between these two agents. The primary endpoint was progression-free survival by blinded review, together with a number of key secondary endpoints, progression-free survival by investigators, responses, intracranial control, time to intracranial progression, overall survival, safety, quality of life. But importantly, in this study, no crossover was permitted. So this is the Kaplan-Meier curve for the primary endpoint that everybody's been talking about, a really very impressive improvement in progression-free survival by blinded independent radiology review with a hazard ratio of 0.28. One thing we should recognize is that perhaps the median of the crizotinib arm identified here was perhaps a little bit lower than we would have anticipated, and how this contributes to the hazard ratio needs some further consideration. But let's look at the subgroups to see what major differences might be hypothesized. We see a huge benefit in patients with CNS metastases, a spectacular PFS of 0.20 and a very effective PFS of 0.32 in patients without CNS metastases. Very important numbers for you to know and remember. But importantly, I think this needs some further consideration. Why is it that the Asian patients had a progression-free survival of 0.47 compared to the non-Asian patients with 0.19? You know, is that meaningful, and why might that occur? And we need to see those Kaplan-Meier curves to get a better understanding, I think. What about the adverse events? Well, the adverse events are, as we have seen previously in the relapse setting, dyslipidemia being a major problem, which can be abated with statins, peripheral edema, weight increase, which we've seen as previous ALK inhibitors have come through, peripheral neuropathy, but interestingly, cognitive effects and mood effects here, which summarily compromise up to about 50% of the adverse events that patients are reporting. So a number of key questions, I think, arise from the CROWN data. Well, look, on the face of it, the intention to treat progression-free survival hazard ratio 0.28 is undoubtedly the best that we've seen from all the phase 3 trials. But what accounts for the control arm performance? Is it just the way the chips were dealed out? Did anything contribute to that? What was the effect of dose reductions, both on the ITT PFS and the PFS intracranially and extracranially? Why is there this difference that we see in Asian patients? So, for example, in the brigatinib trial, Alta-1L, the Asian patients seem to derive great benefit compared to the non-Asian patients. What are the granularity of the adverse event outcomes, and what are the further details on quality of life? Importantly, if we are using lorlatinib, potentially the best drug, up front, what are the resistance mechanisms that we're going to see? Are we going to be able to use any ALK inhibitors after lorlatinib? And are we going to gain in PFS but compromise by OS? So do we need to wait for more mature PFS and an indicator of more mature overall survival before making any decisions? But look, I spent some time putting all of these trials into some tables so that you can try and compare. But there are some key differences in trial design, and I think we need to bear these in mind when making cross-trial comparisons. So most of the recent trials look at IRC, or Independent Radiology Committee review, as the primary endpoint, but there are some major differences in the proportion of patients with CNS metastases going into the trial, which undoubtedly will affect the median of the ALK inhibitor that we are seeing, but probably or may not impact on the hazard ratio depending on the amount of intracranial activity that we see. CROWN had a relatively low number of patients with CNS metastases treated with radiotherapy compared to Alta-1L, and there are some differences in the types of patients with ALK positivity that recruited into the trial. When we look at the comparative efficacies across all of the trials, we do see some differences. The response rates across all of the trials seem to be broadly similar: alectinib, brigatinib, ensartinib, and lorlatinib. But we do see differences in the ITT progression-free survival 0.21 and 0.28 for crown, compared to what most of us have been using for some time, alectinib 0.43 and 0.50, and 0.43 and 0.49 for brigatinib. But we start to see some key differences when we look at when we look at progression-free survival for patients with CNS metastases, which can be a problem. So, for example, looking at the PFS in patients with CNS metastases, we see a hazard ratio of 0.2, which I suggest would be very similar to what we're seeing with brigatinib, but is superior to what we've seen thus far with alectinib. But a very impressive hazard ratio of 0.32 of patients without CNS metastases, compared to what we've seen with alectinib and brigatinib and sartanib to date. And importantly, in those patients with intracranial disease, looking at the response rate of target measurable lesions, we see a very spectacular response rate of 82%. Now, whether this is similar to what we see with brigatinib or not, you can debate about, but undoubtedly, both of these drugs with very good intracranial activity. What other things do we need to think about? Well, apart from the cost, which is a key driver in Asia, obviously, we have to think about other things. Do we give it with food? Do we give it without food? How many tablets does the patient have to take a day? And what other considerations do we have to think about in terms of drug interactions for these different drugs? Undoubtedly, lorlatinib is 1 pill per day. I don't know the cost in India, but there are interactions with CYP3A inhibitors and inducers, and of course, the statins rely on this pathway as well. So there will undoubtedly be interactions between the statin that you choose and lorlatinib that you give for your patient. So there are multiple issues to consider when thinking about cross-trial comparisons. How was ALK classified between the different trials? What was the percentage of CNS metastases in each arm? Was progression-free survival reported and measured by independent review or investigator review? And these were generally open-label studies. Were patients stable or treated with CNS metastases when they were enrolled? How was the intracranial response rate measured? Was it blinded or investigator assessed? And was it measurable disease or all disease, measurable and non-measurable? Were responses confirmed or unconfirmed? How were non-target lesions progressing that required radiotherapy handled in the trial? For example, if you had a 1 millimeter lesion which was progressing to 8 millimeters, it wasn't a target lesion, but was still moderately big and may have required radiotherapy. Is that an event or not an event? And does it classify as a progression-free survival event for that particular trial? So I'll conclude by saying that upfront next generation ALK inhibitors are now standard, and lorlatinib is undoubtedly a highly active drug in the CNS, both after crizotinib and other ALK TKIs. After the next generation ALK TKIs, the CNS response rate is much better than the extracranial response rate, and the efficacy is greatest for lorlatinib in the relapse setting if you identify an ALK resistance mutation. Lorlatinib is undoubtedly a highly effective next generation inhibitor compared to first-line crizotinib, both in terms of the ITT population, patients with CNS and without CNS disease, but it has an unusual adverse event profile which does require proactive management. And we do need to have a better understanding of the resistance mechanisms to first-line lorlatinib use. And with that, I'd like to thank you for your attention.